As everybody filters in, thank you all very much for joining us. This is as many of you know, this is our quarterly journal club. My name is Eric Wagner, and my partner Chris Clifto are going to sort of go through this just similar to other ones with our expert panel. We're really lucky to be joined by some true experts in proximal humerus fracture fixation and different options regarding proximal humerus fractures. I know many of you are excited, as am I, about learning a fair amount about this. It's a pretty complex topic. And I really want to to start out with, thank Hats, Serena, and Mark for joining us. And we also have a special guest, Grant, that I'm going to poke every once in a while and hope that he contributes given his special interest in this area and expertise in this area. Chris, anything you want to say before we get going?
No, that was great, Eric. Please send your questions. This is so much more fun when we get to ask the panelists what you all want to hear. It makes it more interactive. So feel free to ask the questions and we'll relay that to them and get some answers for y'all.
Perfect. All right. So without further ado, we're going to start on our first article. This is the non-operative article that I previously sent out. So this is looking at the functional outcome of proximal humerus fractures treated non-operatively. They looked at an outcome of 1 year. 774 patients total were included, a mean age of 66 years, 74% female. So interesting enough, they really were looking at functional outcomes. So the Oxford score, the EQ-5D, the UCLA activity score, VAS health score. In general, there's a huge variability in functional outcomes at 1 year, and that's kind of the take-home message from this. You know, the Oxford score average was 33, but there's 31% with over 47 and 21% with under 24. So huge variability. And interesting enough, at the EQ-5D, 16% of people had scores worse than death. So it's about as bad as you can go. Overall, worst outcomes shown in table 3 and 4 via unit and multivariate analysis kind of showed that it was really social. So higher level dependency, social deprivation, and mood disorders. There was some impact of fracture translation, tuberosity displacement, leaving the non-unions. And interesting enough, of the 10% that developed non-unions, 60% of those, so more than half of those non-unions had a worse than death EQ-5D score. So it kind of really highlights that there is a diverse range of functional outcomes with proximal humerus fractures. As figure A and figure B show, 3A and 3B show, as well as 4A and 4B, there's really similar type of fracture patterns that have very significantly different functional outcomes. And it kind of helps demonstrate this variability in this really nicely done study. They also really highlight, as many others have shown, the importance of social factors, some of these fractures, and then kind of sets the foundation for further investigation into these patients that are high risk. So I'm going to sort of start out, Hats, it's okay with you, I'm going to ping you. Are you able to predict who's going to do well and who's not going to do well with these non-operative treatment of proximal humerus fractures? Through the years, have you been able to sort of come up with a pretty good algorithm predicting who's really going to fly through non-operative management when you see a patient?
That's a great question, Eric. I think it's interesting. You develop your way of treating these fractures, and so you don't get to see how they progress after you fix them. Let's say if they had done non-operative treatment, depending on what modality you have, I think it's based on a lot of people that come in after the fact, treated non-op elsewhere or a year ago or 2 years ago. And the consistent factor I've seen is these varus fractures, like in figure 5. So if you have a fracture like in figure 5, it starts out in varus. Those typically don't do well in my mind. And by going to 45 degrees of angulation, saying, well, it's not quite displaced because it's angulated 35 degrees in varus, particularly for active people, even older active people, even in their 80s. The same authors showed that a lot of these patients were independent before the fracture and became dependent afterwards. So I think that's where the purpose of this journal club is awesome, to determine better outcomes for operative treatment and prevent those complications of non-op management when it's inappropriate.
Yeah, that's fantastic. So Serena, going off of what Hats is saying, so what are the important things that you tell your fellows when you're deciding somebody that's like an optimal non-operative candidate? So when you're looking at the imaging, when you're looking at the kind of fracture characteristics, what are some of the things that you tell them, this is going to be a poor predictor, or this patient's going to do quite well with this?
Yeah, I mean, I think I'll preface this by saying that I have a lot of really horrible looking x-rays out there of patients that I've treated non-operatively. And a lot of those people are really happy. And I don't know why. They're impacted. Some of them are subluxated, they're joint subluxated. They do not fit any of the criteria that were talked about in terms of head shaft angle being less than 140 or translation of the medialization of the shaft. They check all those boxes and they're very happy. So in general, I think you can't necessarily predict based on imaging, but I will say that if you have somebody that has no cortical contact, they have shaft medialization where you think it's going to abut the glenoid, inferior glenoid. Sometimes you see those fractures. I think those are bad predictors. Smokers, especially heavy smokers, are going to be at increased risk for non-union. And then, like Kat said, those really varus angle fractures. I think it's interesting. This article talked about all of the psychosocial factors that predict a bad result with non-operative treatment. It's not like those change if you operate on them. So it's not like suddenly you operate on them and the patient has family support and they don't have complications. So I think we have to be a little bit careful how we kind of look at this data. Those are probably predictors for who does poorly, regardless of what we do.
So how do you take those into account? Do those impact your decision-making at all?
They do. I mean, they push me towards non-operative treatment. So even though those are poor predictors of their outcome, I still think that with those factors, they're going to do worse with surgery. And a lot of those people are people with multiple medical comorbidities, people that you wouldn't necessarily put through an operation. And so we're accepting that they may have a poor result. And in a lot of ways, so is the patient.
We got a guest celebrity here, our president, Dr. Duraldi. Thank you for joining us. He has the first question for the panel. What were the flaws of the Proffer study that promoted non-operative treatment? Maybe we just go down the line. I'd love to hear what you all think of the Proffer trial and the flaws of that study.
Great question.
Dr. Mile, you want to field this one first?
Yeah, I'm happy to. So, I think that got a lot of traction because in a lot of the healthcare systems where they're really trying to save dollars, they don't want to operate. So the biggest problem I had with the Proffer study is that there's so many different surgeons. So if you look at the Proffer study, it wasn't like 10 high volume shoulder specialists who do 100 shoulder fractures a year. It was generalists, it was sports medicine doctors, it was hand surgeons, it was across the board, and people who did, just a few. So, one of the hardest things we have is that, even in our society today, these go out to everywhere, and there are people who may do 100 a year and there are people who do 2. So that's first and foremost one of the biggest problems I have with the Proffer study. I think that they're not really looking at shoulder champions when they're looking at the results.
I'll chime in with the second one. That's a great one. The other one is, if you look at the inclusion criteria, they only included, the exclusion criteria, they excluded all fractures that met operative indications. So in other words, you're randomizing people and you're taking out the ones that would have benefited from surgery, and then you're randomizing the ones left over. Well, of course, you're not going to see any difference. So that means the study is dead on arrival. That one sentence in the methods paragraph completely invalidates it for me.
That's why it's published in an internal medicine journal and not in an orthopedic journal. That's all I can say about that.
The other thing I'll add is, I think in general, randomized controlled trials are terrific for answering questions. When it comes to surgery, you have to really think about how generalizable is this to my practice. And so if I went into my room and I told my patient with a proximal humerus fracture on Tuesday when I do clinic that we were going to flip a coin, and if it came up heads, they'd have surgery, and if it came up tails, they'd have no surgery, would they be okay with that? 99% of my patients would say no way. And so the patients that were actually enrolled in this study, you have to wonder, what kind of people are they? Or are they the same type of people that you would be treating in your clinic? And for me, I can say that they're not. But I love this study because this gives me great reason to treat certain patients non-surgically with very valid data that supports it for sometimes really severe fractures.
That's awesome. Hats, do you have anything else you want to add?
Well, I think a better study is actually by the same author, Robinson, who looked at the translated 2-part surgical neck fractures. And to Serena's point, there are some horrible looking x-rays in there with the 90% shaft displacement and these weird zigzag fractures that have healed in debilitated patients. And they are doing, quote, fine but they really haven't changed from before. They were dependent before, they're dependent afterwards. The real data comes from looking at patients and saving their independence, saving their satisfaction with their quality of life. And the Proffer is horrible at that. So I think it's useful to have some data like that. To Mark's point, there were interns and residents and registrars. It was in England. It really speaks to the way we need to improve on this is, can you make a standardization of treatment, whether it's with a plate or a nail, whatever treatment, standardization of technique, and then even minimum requirements of how many cases someone has done before you do a study like this, because someone shouldn't just slam in a piece of hardware in a proximal humerus fracture. They have to know how to do it, and it's not an easy thing. So that's one of the reasons why we're still discussing this for the last 30 to 40 years, because we haven't perfected that.
I think one thing, and Seren alluded to this with his comment about the patient expectations, is, we have the NEAR classification that can tell you a little bit about AVN. We have the paper we're discussing today that can maybe tell you about non-union risk. We have the work of Dr. Spross and Jost that have shown us about bone quality, right? But the big thing is the patient activity, patient demands, what do they want to do with their arm? That's such a huge factor in how they're going to cope. If that patient comes in and says, hey, I enjoy reading and bridge, non-op, it really doesn't even matter what that x-ray looks like. If they say, hey, I want a chance to get back at overhead tennis, et cetera, then it makes it a more complicated scenario. So I think the patient demand is such a huge part of it. We just really don't capture that in any of these studies.
Yeah, that's a good point. Incorporating physiologic age. How do you capture that in a study if you're going to design one, Grant? Like, what would be your, because it's not even just like defined by age, right? Because there's 70-year-olds that are extremely active and there's 50-year-olds who are not. So how do you capture that?
It's definitely not defined by age. There are some activity scores that are validated, and people are starting to incorporate that into their studies going forward. And I think that's a really positive thing. And I think that's maybe going to hopefully help us answer some of these questions.
Absolutely. All right. So Dr. Mile, your fellows are about to take their boards in 6 months. When they are approaching this, what advice do you have when they're approaching these proximal fractures? What advice do you have when making these decisions that maybe it's not entirely clear, given there's support for almost anything that you do with these proximal fractures? How do you advise them to approach these?
So I don't know if the question was the boards. My fellows just ace the boards. They're great guys. They do wonderful. Their ladies do wonderful every time. But I wanted to kind of get to one thing, that when you look at proximal humerus fractures, and you brought that up, there's a whole gamut. I think, physiologic age is, to me, one of the more important things, because that goes to what, Grant was saying, younger, more vibrant 70-year-olds who still want to go rock climbing and play pickleball are very different than someone who comes in a wheelchair. And I have the same patients Serena has. I'll tell you that probably 70% of my patients are non-operatively treated. I have horrendous x-rays, but one of the things I've noticed is that if you take out fracture dislocations, if you take out patients who have a head split component, that leaves the majority. We talked about the varus fractures. The one thing I don't like is if I see the greater tuberosity sitting on the top of the humeral head. Those have never done well for me with non-operative management. So if it looks like a Frenchman, you want to not fix it, because I think when it scars in on the top, those patients tend not to do well. And then it's cortical continuity. I think we talk about shaft displacement and displacement in general, but once you get away from about 50% to 75%, now I start to get a little bit more nervous if it heals, especially to Serena's point, the ones that are medial, because they abut the glenoid. So that medial displaced greater than 75%, a fracture where the greater tuberosity is over the top, those start to drift into my surgical criteria. But I asked the fellows, and you said that in the beginning, number one, can non-operative treatment work? And if that answer is yes, it's the first choice on the board's exam, and it's the first choice in my clinic.
Perfect.
Yeah, there's that great study showing that if you had over 50% translation, there was a higher risk of non-union that just came out in JBJS. So that was a great point, Dr. Mile. Okay, so let's move on to the next one, titled "The Displaced Humeral Head After Intramedullary Nailing for Proximal Humeral Fractures is Associated with Worse Short-Term Outcomes in a Multi-Center Tron study." This is a study out of Japan that looked to explore the outcomes of IM nails for proximal humerus fractures in the elderly. because they stated that few studies have been completed to evaluate the outcomes. They collected data on patients over the age of 60 and 30 at 13 centers. Patients were excluded if they had less than 6 months follow-up. UCLA scores less than 27 were considered to be a poor result. They analyzed radiographic outcomes, including humeral head height, head shaft angle, and cranialization of the greater tuberosity, and categorized them into two categories, just poor and good. There was 243 patients that were included at a mean age of 76. Mean follow-up was 12 months. They found a weak correlation between humeral head height, head shaft angle, and cranialization of the tuberosity. Humeral head height of less than 0 millimeters and greater than 10 millimeters was associated with poor UCLA outcomes. So let's let the controversy begin. Hats, you maybe do more IM nails than anyone in the country. What are your indications for these?
So displaced two-part surgical neck fractures are a no-brainer. Valgus impacted fractures, those are both indicators for percutaneous fixation with a nail, in my experience. You can do 3- and 4-part fractures percutaneously if they're amenable to reduction maneuvers that you learn over time. But also performing an open exposure through superior approach, a true superior approach, not a lateral approach, also can work well for those. So basically, when you start, it's 2-part fractures, which are about 50% of displaced fractures. And then once you learn how to convert multi-part fracture to a 2-part fracture, then you can percutaneously fix those fractures as well with excellent results.
What do you think of the radiographic outcomes you're describing? From your own patients having so many, do you find that these radiographic outcomes correlate to your patient outcomes?
Yeah, it just shows that it was a few problems with this study. They didn't really clarify when they looked at the x-ray, so I assumed it was immediately post-operative, but they didn't quite define that. But if you're graded, just like Mark said, if your graded tuberosity is sitting above your humeral head, or the humeral head's angled in varus, or the graded tuberosity is way over reduced, that's going to create a poor outcome whether you put a nail or a plate on it. This was 80 surgeons with 6 different implants and no real standardization of treatment. So I can understand why they had some of those poor reductions. And really the critical key is if you don't anatomically reduce that fracture or near anatomically reduce it with the relationships that we all understand, you're going to have a bad outcome no matter what you do.
Awesome. Serena, when you're considering a candidate for a nail, one, who in your mind's ideal candidate, and then 2, what's going to push you more towards a plate versus more towards a nail?
Yeah, so I nail almost nobody, but people that I would nail or I have nailed have mostly been very elderly people with widely displaced 2-part fractures, where I thought, and it was fresh, where I thought I could do it more percutaneously, less invasively than I would a plate, and get some of the load sharing benefits of having a nail inside of the canal. But I think, I do very few nails. And so I could have been one of these centers in this study doing a poor reduction. Then the study comes out where it says, maybe nails don't get great reductions, but really it's the fact that I do 2 a year and I'm just not as good at it as Hotz is.
Well, Serena, you're a well thought out guy. Why do you only do 2 a year? Why would you do 2 a year or none a year? What's your, why don't you like nailing?
Yeah, I mean, I think for me, it's been the potential for cuff issues. And Hotz will tell me that's not a non-issue because he goes more medially and goes through the muscle. But, some of the nails traditionally that I was trained on and I used went through the cuff. So I've always been reluctant to do that. I felt like for me, getting the reduction has always been easier with open technique with a plate. So I think the point that was made about reduction quality is over and over the most important part of getting a good result with a proximal humerus fracture. So whether you nail or plate, I don't think it matters. It's just getting the best reduction you can get. And so for me, that's been open with a plate. So I think Hotz can nail things that I can't, and that's just the way it is.
Well, we got a question from Michael Knudsen. Says, can the panelists share their technical tips on opening and repairing the cuff in the setting of nailing these fractures? In the few nails that he has done, he has seen cuff pain, even in the careful splitting of the cuff and repairing using 3rd-generation nails.
Does anybody want to take that?
I see Hotz getting red. He started a bubble.
That's my Dallas sun exposure.
That's how he always looks, Serena. That's just him. Yeah.
Greeks don't get quite as olive.
Grant or Mark, do either of you want to chime in before Hats takes us?
I'll only chime in and say, and probably what Hatzidakis is going to allude to, is if you are putting in the nail, most of the current techniques have drifted towards splitting through the muscle. So you really shouldn't have to fix the cuff when you put in the nail. And I know that, Pascal is now going through a Navisor portal with a tiny nail and getting into the cuff and getting good results. So he actually enters through the actual Navisor portal. So I think that getting away from having to cut the cuff when you're using a nail is a way to do it. I'm gonna have to plead the fifth with Serena. I'm one of those individuals that only for pathologic fractures and some elderly do I do nails. So, I fall in that same category. But, what I think it is, and just real quick, if you're really good at something, if you should stick to that because you can be more predictable in your results. If you start using a bunch of different devices every single time, or if you have to read the technique manual the night before, it's probably something that you're not super comfortable with. So I think that you do what you're comfortable with. That gives the patient the best chance. But split the muscle, don't go through the cuff.
Absolutely. I think that's great advice. I'll give you the kind of lower volume nailers perspective before Hotz tells you the master course. So for me, indications are if you have a displaced two-part fracture in an elderly person where you just want to get the ice cream back on the cone. I have not done multi-part fractures with the nail, even if it's non-displaced tuberosity fracture. I just want that true surgical neck fracture, but it's in an unacceptable alignment, and I just want the load sharing that Serena mentioned. So for me, I'm also not doing the Navisor portal or the trans AC joint or any of those other things. I just do like an open rotator cuff approach, a superior approach, where I'm basically taking down the anterior lateral FA, taking the anterior deltoid off the anterior acromion. I repair that with a couple sutures through bone tunnels. The error in that is it makes you want to be more kind of lateral and anterior with your starting points. You really got to make sure you get posterior to get to that muscular part of the cuff and get in the highest point of the humeral head. But with those pearls and little sutures in the cuff, joystick wires to kind of get the humeral head up, I mean, it's not complicated if you make an exposure like that. Even somebody like me can do it.
All right, Hats, can you give us some tips on both with regards to the cuff, with regards to your approach, some technical tips on getting the reduction perfect?
Sure. I think the tips that are brought up were really good. The key is getting away from what the product manuals taught us 15 years ago and staying and going lateral. And even the study said deltoid split. What the hell is that? You could split the deltoid anywhere. So the key is positioning, starting with positioning, keeping the elbow, the humerus extended in comparison to the shoulder. And then the humerus becomes more prominent up front here, and then just going right anterior to the AC joint. And if you put a hemostat in that position with your arm adducted, extended, and your fracture is relatively well reduced, then that goes through the muscle of the cuff. So the problem is at that point, if you want to make a lateral exposure here or even anterolateral, it still goes too lateral, no matter if you use a bent or a straight nail. So what I've gone totally to, and Pascal was the one I thought was crazy at first for talking about this, but it works out really well. It's just a little incision in front of the AC joint, not through the AC joint, but in front. And then using a hemostat to spread. Usually you get right to the top of the head because you're going through muscle. Yep, don't have to go through tendon. And so that's the entry point. The entry point is the anterior. And even Chris has had a great study showing deltopectoral approach or high deltopectoral approach with the same exact arm position that does the exact same thing. It's really a high deltopectoral approach. As far as reducing the varus fractures, which are the ones that we're really trying to get that ice cream cone on top, it's a head lift maneuver, making a little bit of a percutaneous incision right at the level of the fracture. And passing a blunt elevator like a small cob under direct image intensification, looking at both the sagittal view and the coronal view to look at the two positions of displacement, and then lifting the head, not levering the head, but truly lifting it using your force on the handle of the cob. Valgus fracture going under the lateral aspect of the head and lifting the head up, and usually the tuberosities fall into place. Pin it, and then put in the nail through the exact same approach, anterior. So I used to start by going here. So first it was here, just like the product manual said, and then went to the anterolateral approach like D'Ambrosia first talked about, but really the best entry point's right here. And that's, if you feel your own shoulder, that's kind of the soft spot where you're between the deltoid and the pec, and you're going through the muscle at cuff. And then the arm has to be in a good position. So really, when we teach this, it has to be the same way every time. It can't be playing around. Well, maybe I'll have the arm in this position, or maybe it'll be sitting against the abdomen. There has to be an arm position or arm in neutral, arm extended, and then through that front of the shoulder. And that typically gets good clinical results without much pain.
Yeah, I'm a nail enthusiast as well, like Hots. And if you're going to do it supine, not in the beach chair like he's describing, make sure you put a really big bump underneath the shoulder, because that's the only way you're going to actually access any entry point. Grant, follow up. Neil and Benview from USC said, what's your thought process on having a load sharing device for two-part fractures versus a locking plate? Are you worried about poor bone quality, or is this something specific about two-part fractures? You mentioned you'd like to do these for two-part fractures. What do you think?
I just think that the idea of kind of that medial column support, some people use intramedullary fibulas. I'm not a big fan of that if I'm going to have to revise that to an arthroplasty in some of these older patients with poor bone quality. For me, having something that's metal and removable that can sort of be more along the axis where I'm not having that cantilever bending. So again, we're talking a lot about varus fractures, especially fractures where the calcar is fractured. Those are the ones that are really bad actors as far as varus angulation. So, so maybe I'm not being careful with my language, but load sharing along that medial column. And I think the nail gives you that in a nice way.
These are great questions, by the way, guys and girls. Keep them coming. They're awesome.
Very cool. And yeah, please keep interacting. Don't be shy with asking us. So real quick, so what is the future? So Pascal Below and others have come up with this idea of being able to save the cuff, and I think that definitely has changed us. What is the future of nails? Are we ever going to get to the point where we're like our lower extremity colleagues, where we're nailing all these fractures? Like what do you guys see coming down the pipeline?
Well, just one thing I think that people don't talk about much is the angle fixation. We're so used to coronal fixation from lateral to medial. And what's really cool about intramedullary fixation is you can spread your fixation more on the sagittal plane. And not many of the nails do that. I'm conflicted because I've helped design one device that we use now that does have that. But really, that's where the tuberosities want to go. They want to leave around the back and the front. And then also, if the head's going to displace back in varus, those screws going through the head in one plane, lateral to medial, the head falls in varus and it just rips through the fixed angle device, whether it's a plate or nail. If you just diverge those screws and transfix the humeral head in a two-part fracture, or compress the tuberosities in multi-part fracture, that's ideal fixation for these fractures. So I think once the folks learn the technique of doing this, every panelist on this call could easily do this after a couple of cases and feel comfortable with multi-part fractures. I actually don't do as many as I used to, and you don't have to do a ton of these fractures to get good at them. And my junior partners do these cases, and they do it with the nail, not because I tell them they have to, but they try a few and they're like, whoa, they heal a lot faster. It works a lot better. And it's not just the old patients, the younger patients, and the people who just want a minimally invasive technique with rapid healing and where you don't disrupt the blood supply. But I think that fixation is really the key, Eric. The direction and the mode of fixation is really one mode of improvement.
I'm going to poke my partner. So Clifto, you're a young surgeon in your career, and you just started out, but yet you've been really taking this head of steam. Can you give some advice to people that are just starting out their practice, taking on this technique that maybe they haven't seen as much as plating or some of these other techniques they do in shoulder fellowships?
Yeah, I think it's like what Hat said. You choose your fractures appropriately. Like the 100% displaced two-part fractures is probably the best one to go. The varus proximal 1/3 fracture, I think, is also one that's highly successful with a longer nail. Those have been the ones that have the most success. Trying to go through the rotator cuff medially or an alternate start point has been highly successful. We're doing a study right now looking at shoulder pain using these portals, and they're substantially less than going through the cuff. So figuring out ways to minimize cuff injury is the way to go. And just take your time with it. They do really great. And it's all about setup. Like you have to, like with my residents and fellows, like we don't start the case until we can get every single x-ray. I use a Jackson flat. And once we have that set up, the case is easy. But if you don't have a huge bump on the shoulder and preoperative x-rays that are perfect, you're not going to be able to do the case. So spend some time doing that.
Perfect. And then before we move on, one last question. So Hats, when do you think nailing is not appropriate? When are you plating? This is from Brian Davis.
So I'll plate a non-union when I want to expose the non-union site and prepare it and freshen it up. But for a non-fixable fracture, like trying to push the envelope too much, trying to put multiple head fragments together, or if the greater tuberosity is just crushed and there's not good bone on a multi-part fracture, it's time to bail and do a reverse.
Awesome. All right, so moving on to the next article, we're going to be looking at open reduction internal fixation plates, particularly focusing on some of the factors that are associated with poor function after this. So this is a retrospective study, 3- and 4-part proximal fractures, greater than 2 years follow-up, and they really wanted to look at which factor predicted poor outcomes, or constant scores less than 55, or revision, surgery, non-unions, or AVN. They looked at ultimately 48 patients, although there were 57 eligible. Some were excluded due to loss of follow-up. Their minimum follow-up was 2 years. Their mean follow-up was 48 months. They looked at in their study, they had a 92% union rate. Their mean constant score was 68, but they did have 21% with that constant score less than 55. They had a 15% revision surgery and a 21% AVN risk. And when they're looking at the fracture, looking at some of the poor functional outcomes or complications that the factors that predicted these, they looked at that. They found that patients with an absence of back bleeding from the humeral head probably was the most predictive. Absence of metaphyseal head extension, head height segment less than 2 centimeters, an absence of capsular attachment to head fragment, and then 4-part fractures. They also found that women had a little bit higher risk of poor outcomes, and interesting enough, energy, posterior dislocation, age did not. Obviously, the study is limited by its underpowered nature, single center, retrospective nature. Nonetheless, it does identify some clear factors associated with open reduction and internal fixation, some considerations in performing this. It also kind of supports the difficulty of some of these 4-part fractures, especially those involving the anatomic neck, as they pointed out, with many of their fracture characteristics, and kind of contribute to this emerging literature. So I'm going to start out with you, Mark, if that's okay. What factors do you consider have the biggest impact on your outcomes after your plating fracture? So what are the ones that you are either most nervous about, or the ones that you have seen through your experience that seem to have the biggest impact on maybe not necessarily getting the best functional outcomes?
Well, first of all, that study was fracture dislocation, so that falls into you're going to have surgery because now you have a fracture dislocation. But if I have a case where there is, where there is a fracture with relationship to the humeral head. When you get a humeral head, that there's not much left of it, so it's more of a anatomic neck fracture. Those for me have gone on to AVN. I have tried to fix some of them because they're younger patients, and so I worry with that particular patient. Cases where you have a neurologic injury in conjunction with the fracture, I just have not had great results. If I fix it, you got to fix it. But if they have a brachial plexus injury, which is not unusual with a fracture dislocation, so neurologic injury, anatomic neck fracture. And then I think time matters in fracture dislocations. I mean, I'm not saying you have to operate on it that day, but I think that delaying that too long will impact upon fracture healing.
And what is that? What is that magic time point? Is it a week? Is it a couple of weeks? Like, what do you think when you really start getting nervous about it being too long?
I like to bring the patient in within a week if there's a fracture dislocation. If I can do it the next day, I'll do it the next day. I think those are the ones you want to get to a little quicker.
Yeah, that makes sense. All right, so Serena, when you have a patient that has an anatomic neck, a true 4-part with the anatomic neck, and you decide to fix this, can you share some sort of technical tips or strategies in getting that perfect and sort of really getting that reduction, as you mentioned, as good as possible in the prior discussion?
Yeah, I mean, I think first in terms of approach, I'm now Delta Pec. I used to do some deltoid splitting, and I think it can be easier to get to access to the greater tuberosity, and in some ways makes your ability to get a reduction easier. But the worst outcomes that I've seen of conversion to reverse have come in failed proximal humerus fractures from a deltoid split incision, especially if there's been anterior deltoid loss. So I'm strictly Delta Pec. In order to, I think, get the perfect reduction, which I think is the primary goal, I think there are a lot of different techniques that can work. I mean, for me, I don't use the hardware to get the reduction. I want my fracture reduced before I put the hardware on it. And so I think the hardware matters a lot less. My approach is to first reduce the head to the shaft and pin it there. I put all my pins around the periphery in order to both retract the deltoid out of the way and to prevent levering the head. I think if you use a Brown retractor or a Homan retractor to retract the deltoid, you end up levering the head anteriorly and you actually lose your reduction. So I pin around the head and around the tuberosity in order to retract the deltoid, allow for imaging and work to be done without actually levering the head in any direction. And then I think you have to make sure that you get your calcar restored, and that's either with an anatomic reduction or you get your screws in the optimal position, which we've shown is about 12 millimeters from that inferior margin. And then I use bone graft liberally, and I try not to use fibulas like Grant in these fractures that are higher risk for AVN. But if there are bone defects, I use a lot of crushed cancellous and I pack it in tight to get some supportive fixation. And then I think sutures in the cuff have now been shown biomechanically to be helpful. So I do that routinely.
That's awesome. Fantastic. Grant, do you have anything to add on to that? I know you've done a fair amount of work in this area on really tackling these tough ones, and some technical tips to augment your maybe metaphyseal bone loss or the calcar reduction, anatomic neck reduction.
Yeah, I think just a couple. That calcar piece is key, and if you have calcar comminution, finding that piece and putting a couple lag screws to make that. If you don't have that calcar fixed, you're going to have a really hard time for two reasons. One is that's your medial support. And two is a lot of your pins, once you get the head back on the shaft, are going to kind of get your temporary provisional fixation in that bone. So I think really pay attention to that calcar bone, get that right, and then get that calcar restored. Once you get that right and then get the tuberosities around, everything will fall into place.
And how do you optimize your plate positioning and so you've gotten this reduction, you pinned it. So then maybe walk them through the next couple steps. So plate positioning and then ultimately kind of getting everything secure and taking the pins out.
Me or Mark?
Yeah, Grant. Sorry.
Yeah, so I think the key is you don't want your plate too high, right? Because you don't want impingement, and you want to have those screws low and kind of hugging that inferior part. That so-called kickstand screws are very helpful to resist the varus collapse. So for me, there's little things that can tell you the height of the plate. For me, it's more important where the inferior screws are, and I really want those kind of as low as possible and still in the head. So I put provisional pins in, I take x-rays, and then I actually put a wire up those inferior kickstand screws and make sure I like that location before I proceed.
Very nice. All right, Hats. So is there a role for nails in these difficult 3, especially 4 parts, or in these young patients? Is this your indication for plates? And maybe talk about kind of your approach to these young patients with these difficult high energy fractures.
Yeah, it's actually a good indication for a nail if you know how to do an open superior exposure. The fracture dislocations, you can actually you can release the anterior deltoid off, just a traditional open cuff approach, and split the superior cuff. And usually in 3 and 4 part fractures, even dislocations, the cuff is completely intact and in a nice covering. And so if you can make about a 3 to 4 centimeter split in the superior supraspinatus without releasing any of the cuff. And then the key is getting the head reduced, levering it off of the glenoid. And then a lot of times when you reduce the head, especially if there's some soft tissue attachment, once it reduces, the pieces just kind of get underneath it and come together, because it's really an implosion injury or sometimes an explosion injury. But once the head becomes the keystone, it's reduced against the glenoid. Then just fiddling a little bit with the tuberosity fragments, you have easy exposure to the GT, as Serena said, but you're not extending it laterally to expose the axillary nerve. You're stopping short of that. Converting the multi-part fracture to a 2-part fracture, a pin or 2 to get the pieces together, sometimes a suture or 2, and then placing the nail medially through the top of the head to reduce that.
Fantastic. All right, so Mark, as your career has evolved, how is your approach to these fractures, these really difficult 4-part fractures in young patients? Maybe besides head splits, is there any contraindications for fixing fixing one of these four-part fractures in a young patient and going to an arthroplasty, or with regards to fixing them, how has your practice evolved approaching these young patients with these difficult problems?
Well, first of all, I think that as you are in practice and you kind of observe things, and that's kind of what we get over time, I want to fix the young patients every time, because, when you're doing a reverse for fracture in a younger patient, that now has a limited warranty. And if I can get it fixed, and granted, sometimes you can't do that, but I'll do everything possible. You heard some of the tips. One of the things I think that when you're fixing fractures, more surface contact area, better healing. So if you don't respect, we're used to fixing fractures where we want to puzzle everything together, and it's very gratifying when you see things interdigitate. But sometimes you can actually shorten these fractures where you get the humeral shaft into the head, and it gives you a larger surface area for healing, and you minimize that effect of having a gap medially that these guys were talking about where you have comminution. So on younger patients, on older patients, I really like shortening a little bit to allow for circumferential cortical contact. Love it. I think that the sutures become critical in these fractures, because Xavier had a nice article showing how if you put a stitch in the subscap, you can derotate the head. You can manipulate the head before you impact it to make sure your alignment is good. When you're looking at the greater tuberosity, when Serena was talking about splitting the deltoid, it's never a problem if you put a stitch in the supraspinatus tendon. You can always drag the greater tuberosity back around. So you're almost like a kite boarder, kind of manipulating the head, pulling the tuberosity down. But if you got heavy sutures, they will assist your reduction. But I will tell you that the worst thing you can have is an infected reverse arthroplasty in a 32-year-old male, which perhaps I've had. So, when we're trying to fix these, yes, you can do a reverse, but when that gets infected, now you got a real disaster. But if you can fix them and the majority of them heal, you've got 90% of your patients who hopefully will go a long way down the road without needing an arthroplasty.
Got a question from Casey Sanko. Can the panelists talk about how they talk to patients who have operative 3 or 4 part fractures, but may be considering non-operative treatment for whatever reason? Are the outcomes of RTSA worse if you wait until they fail a trial of non-operative management? Hats, what do you think?
I think it's a totally reasonable approach, especially in those folks who are not good surgical candidates immediately. It probably does a little better to get that GT down in an acute situation, but if you know how to osteotomize the GT and a malunion and can reduce that, it's harder. And the literature would suggest that it's not as good, but that's a lot with old implants that we don't use anymore. And I think with proper technique, you can salvage those cases. The key is the greater tuberosity, to mobilize it and get it anatomically reduced, but it can be done.
Grant, what do you think about that question?
So that's kind of the approach I've taken. So if I think someone is a reverse candidate, and I kind of feel like it's, even if it healed in a malunion, I'd be able to fix it. So if there's like shaft piercing the deltoid, that's a bad one for me. Fracture dislocation was mentioned earlier. That's definitely, I'm going to move quickly. But if the parts are kind of in the general envelope that would be amenable to late revision, I haven't seen compelling data that it's that different now to do it early reverse versus late reverse. Now, there's definitely data that if you do an ORIF early and that fails and you do reverse later, that's worse than doing reverse off the bat. But treating it closed initially and doing the reverse later, I think it's still an open question. So I think the reverse is a powerful backup operation in that scenario, and it makes you a little more cavalier about treating these non-operatively when you know you have an excellent backup plan. So I think that's totally reasonable, and that's kind of the approach I've taken.
How about you, Serena?
I think I agree with a lot of what's said. I think the literature shows worse external rotation if you wait, right? Because you're not going to get the greater back. And that may be not a big deal in somebody who's elderly. The ones that I worry about are the ones where the greater tuberosity is posterior around the back, because when I come back to do a reverse on that one, and it's delayed, there's no way I'm getting that over, number one. And number two, if I leave it there, it may be a source of impingement that could lead to dislocation. So those bother me. And anyone where I think that the head is in so much varus that it's going to go on to non-union, because I think revising that a non-union to a reverse is different than revising a malunited head neck to a reverse. Those non-unions commonly you end up with proximal bone loss, and then it's a very different reoperation and possible complication profile.
Dr. Miley, want to take us home before we do the last article?
I'm just going to say I like to fix fractures acutely. If I really think the patient needs to have the reverse, we're in the driver's seat. You're the one giving the discussion. I think what Serena said, you can say, look, if you wait, the tuberosity heals in the back, it may dislocate. You may not be able to mobilize it. You won't be able to externally rotate. So you're kind of driving the show. I think what happens, though, is that the ones that were like the patient has bad heart disease, they're depressed, they're taking drugs, maybe you think they're an alcoholic, and then you're like, yeah, we can wait and do this down the road if we need to, and you're hoping that they go away. But I think that if you see someone in your clinic, and you can fix them acutely when there's no callus formation, when there's no scarring, that's a nice operation. When you wait, with any kind of malunion, non-union, it is a tougher surgery to do, no question in my mind. So I would actually be the one here saying I would try to talk that patient. If I truly thought it needed a reverse, I would try to convince them to have it done sooner than later.
All right, awesome. Thank you very much. All right, so we'll go to the last article titled The Clinical and Radiographic Outcomes After Surgical Treatment of Proximal Humerus Fractures with a Head Split Component. This was a study out of Berlin. 30 patients with head split fractures were included in a retrospective study. Mean follow-up was 49 months. 24 were treated with open reduction internal fixation, 4 with reverse total shoulder arthroplasties, and 2 with hemiarthroplasties. The overall complication rate was 83%, 88% in the ORIF group, 75 in the reverse, and 50 in the hemiarthroplasty. The most common complication following RIF was humeral head osteonecrosis, which was 42%, and malunion of the lesser tuberosity and screw protrusion. The most common complication following the RTSA was tuberosity-related issues. Revisions were performed in 29% of the initial ORIF patients, with no revisions were performed in the RTSA or hemiarthroplasty patients. 17% who underwent primary ORIF underwent conversion to RTSA, and 12.5% had screw removal due to penetration. The overall clinical failure rate was 50% for the whole study, 50% for the ORIF group, 25% for the RTSA group, and 100% for the hemiarthroplasty group. ORIF and primary RTSA showed higher average clinical outcome scores than the primary and hemiarthroplasty group and secondary RTSA group. And general patients who required revision had worse PROs. The authors conclude that head split fractures treated with ORIF showed high complication revision rates. RTSA resulted in comparable clinical outcomes and complications due to tuberosity issues, but did not require revisions. So the authors concluded that RTSA was the most predictable procedure in these patients. So Serena, by the way, if anyone is at a meeting coming up, go to the gym around 6 or 6:30 in the morning and see Serena work out. It's remarkable. The guy is a hoss, battle ropes and everything. Anyway, so Serena, how would you interpret these results? Do these mimic your practice?
First of all, you know that because you're there before I am.
Well, that's true, but that's fine. Yeah.
I think they do in terms of the ORIF group. I mean, I think these suck. I mean, unfortunately, these are a setup for AVN. It's usually a higher energy injury. So the ORIF group, it's not surprising that they had such a high complication rate. I think it's really hard to make any conclusions with the RTSA and the hemi groups in the study. I mean, the numbers are just so small. The data is incredibly fragile, and I can't say that I've had that horrible of a success with reverse in this situation. I think it's actually fairly reliable. But I think the clinical failure rate for the ORIF group does mimic what I see.
Perfect. So Dr. Mile, do you have some tips in optimizing? So obviously this article highlights some of the potential complications, but so how do you get the tuberosities down? How do you optimize a reverse when you're doing it for any proximal fracture, head split or four part or whatever?
Yeah, I think when you're doing a reverse fracture, I mean, the the kind of cornerstone for me is the first thing I absolutely do is I put heavy sutures, in the posterior cuff around the greater tuberosity. So this is one of those operations that initially is one of the easiest because you take the head out, you have complete exposure to the glenoid. So putting in the glenosphere is probably not really the big problem here. It's making sure you have good control. And if you grab at the tuberosities, you're going to morselize them. You have to have suture behind them. I put 4 heavy sutures behind the greater tuberosity and make sure I can bring it across. That's step number 1 for me. And if I can do that, I'm feeling pretty good. Once I have those sutures in, I want a prosthesis that allows for some type of fixation of porous metal. I don't like cement, so I press fit every single one of my reverses for fracture. We've actually got the series of, I think, 21 right now. None of the press fits actually loosened. There were no revisions. I'm not going to say the patients all did well because my fellows gave me a hard time because 2 died, within the first year. So, I have a 10% mortality rate in that study. But, I think that the prosthesis, press fit, porous metal, that you can get your greater, and I usually, while I'm press fitting it down, I'll pass my sutures so that I know I can get the sutures around it. So at the end, and I actually do this supine with a C-arm to look at my tuberosity while I'm doing it to make sure I like my tuberosity height. And then I fix the lesser also. So I do a horizontal vertical fixation to kind of put that back together.
Fantastic. Chris, you want to get to one of the questions?
Yeah. So this is from Kadar Sabat. If you decide to go to do an arthroplasty in a young patient for luxofracture or head split, do you prefer to go straight to a reverse, or do you maybe start with a convertible hemiarthroplasty? Hans, what do you think?
Yeah, so just to go a step backwards 1 second, on type 1s and 2s in younger patients to try to fix those because there's a lot of soft tissue attachment. And that's where a more minimally invasive approach, I think, can work well. I have several patients who've done well with those fractures. So as far as a convertible hemi, I think for a GT fracture that has really good bone, when the greater tuberosity is really good quality, and it's a younger patient, a hemi I've considered, and very rarely in those patients because usually the tuberosities are poor, and the lesser tuberosity, if it's very convoluted or a poor piece of bone, that's a setup for subscat failures. The tuberosities still have to be of good quality, but the head has to be basically in multiple pieces. But once again, for the type 1 and type 2s, for younger patients, anyone on this panel, these young people I'm looking at right here, if there was one of those fractures, I would try to fix.
Dr. Ball, can I ask you a question that we see every once in a while, and the fellow's always asking me about it. You have a patient who has an obvious axillary nerve palsy, but needs has a 4-part fracture, needs a reverse. What's your algorithm to approaching these patients?
So, at this point, I don't think I would still do the reverse if that's what I thought was the best treatment. Knowing there's an axillary nerve palsy, documenting there's an axillary nerve palsy, because you're tensioning based upon the residual soft tissues. And if you really are kind of in a very systematic fashion fixing your tuberosities, if you get the tuberosities fixed around the prosthesis, that confers additional stability. So when I put the reverse in, I tension it so it's maybe a little tighter when I put it in without the tuberosities on. That's what I'm going to choose for my height. So once I've done that and I add tuberosity fixation, I think that I feel pretty good about it. Now, if you think about fractures, we did a study, the first fracture I did with Mark Frankel probably 20 some years ago. We looked at hemiarthroplasty for fracture and found that in 15 or 20% of cases, there's some form of pseudosubluxation or injury to the axillary nerve. So it may not be from, just an injury where it's badly damaged, but sometimes it goes out for a while. So that happens all the time. And when we had pseudosubluxation, it got better every time. So I would say, don't wait, do it acutely, but really make sure you got good repair of your tuberosities.
That's awesome. That makes sense. Grant, do you want to go on Kader's question? So Serena talked about how his head splits do very poorly, or his experiences mimics his arc with head splits doing poorly when you try to fix them. You have a young patient with a head split. What's making your decision between doing a hemi versus doing a reverse in that patient, or fixing it?
I have not done a hemi for fracture in some time. think the last one I did had a bad glenoid fracture and was in sort of a young patient with weight bearing, but it's got to be a pretty exotic condition. So for me, if I have a head split fracture in a young person, I'm going to try to fix it. I'm going to do a biceps tenodesis. I'm going to open that rotator interval very, very widely. I'm going to look in the joint. I put sort of a curved tomen inside the cuff in the front and back, and I can look right down where that split is. And you can actually get more visualization than you think. I mean, Mark Mile can put a whole total shoulder exposure for an arthroplasty into that same exposure. So, I mean, really working to that rotator interval, you can see a lot of the head split. I think front to back screws with a washer, cancella screws can be very helpful. So, do they all work? Do they do great? Absolutely not. But I think that you give them a chance to heal, you swing for the fences. And if it doesn't, then obviously you have bailout options.
Awesome. So, can you talk to us about some tips that fellows always ask with regards to when they're doing reverse fractures? So maybe talk about, so Mark talked on the cemented versus uncemented, but talk about how you get the optimal tension. What do you do with the glenoid with regards to lateralization, and what's your kind of goals with that respect versus tuberosity management, and just sort of how to really how to dial this in so you get the sort of perfect tension, but also get your tuberosities over.
Yeah. I think a couple things. I mean, most of these people, I think it's important to remember before they fell and broke their arm, they had normal shoulders or near normal shoulders. So they don't have a lot of premorbid pathology. So that comes into play in a couple different ways. You commonly don't have to do super aggressive capsular releases like you might for an arthritic patient. It's the easiest glenoid exposure you'll ever get because the tuberosity is totally mobile. You have to be a little careful when you ream the glenoid because the subchondral, the bone is not as thick because it hasn't been loaded like it has in an arthritic shoulder. So if you try to over tilt them inferiorly, you'll end up over reaming them or having to accept significantly more, base plate off of bone. So you have to be careful not to over tilt or over ream. And then when it comes to setting the height, I mean, I look at how much bone is attached to the head segment that I removed with the calcar. If there's no calcar attached to the head segment and the calcar is still on the shaft, which usually there is some, I set my height where my reversed is just going to sit right there like it anatomically would. There's no reason for me to think that my reconstruction shouldn't match what would be anatomic for that patient because they don't have any pre-existing disease. So I set my head height right at the calcar, and then I'll do everything off of that. I think Mark's point about your feel when you're judging your tension is so important because I think some of these they lose motion because we put them in too tight. And this is not the nerve injury one, but I'm talking about just generally, because the feel that you get when you test your tension without the tuberosities reduced, it'll feel loose, it'll feel sloppy. But I pretty much always use a 0 poly because I know there's no premorbid pathology. I know it's going to feel stable as soon as I get my tuberosities reduced and fixated. So, I make sure that I have my height at the calcar. I use a 0 poly in just about every single case. And then I reduce the tuberosities and it's stable. So, I think those are the kind of pearls that I use.
How do you set your tension, right? Because I just did 2 today, and the residents asked me both times, how do you set your height? And then how do you set your poly based on that height? How do you know if the stem's too high or too low to appropriately tension or reverse for a fracture?
Well, I think if you see your calcar, that's where your reverse would normally sit. So my stem in a regular reverse, whether I'm doing it for arthritis or cuff arthropathy, the medial part of the stem is sitting at the medial calcar. And so if I see the medial calcar, that's exactly where my stem needs to go. If there's no calcar at all, which is uncommon, I'll measure the amount that I'm missing and I'll cement it to that amount. But in almost all cases, there's some calcar that you can use to reference your appropriate height. And I put it right there.
Wonderful. Dr. Mile, anything else you want to add or contribute before we
No, I think I agree with most of what's been said tonight. It's always nice to have some kind of discussion. The one thing I will say is that, as you see, Armand does it one way, I do it another. Maybe Serena does it a little different. Grant may do it different. Chris may. So, my one piece of advice is if you don't do a lot of shoulders, stick to one plan and strategy when you're fixing them, and don't try to do a bunch of different things, because that way you can kind of hone your skills with whether you're a plater or a nailer. I mean, shoot, some people even use, suture techniques with really great success. So I would say try to hone your skill and have a strategy and stick to it, because as Chris said, he has to do this setup. It's very important for him to have the patient position just right. So I wanted to thank all you guys, and especially the audience for participating. That's my small dog that's kind of losing it now. So I'm gonna go mute on you guys.
Feed that dog, for God's sakes.
All right, everyone. Well, thank you very much for joining us. A special thank you to Armand, to Grant, Sren, and Mark. You guys were phenomenal. It seemed to be lots of great discussion. This is some of the most questions we've had and some of the most interaction we've had. So really, thank you very much for joining us and teaching us about some of the more common and difficult things that many of the fellows are going to be starting out with early on in their careers. So thank you all. This is recorded and it's going to be online. In part of the email, you can find the link to it, or just reach out to me and I'll direct you to where these are recorded. We have all the ones recorded back to when we started this. Chris, you wanna close it out?
Yeah, no, and I think, Eric, the next one's elbow arthroscopy in 3 months. Is that right? Yep.
Yes.
So we'll be doing it again in 3 months on elbow arthroscopy and some of the controversies there, and we look forward to seeing you all then.
All right, guys. Have a
Thanks,
good night.
guys.
Good night.
Good night.